Hello, everyone. We're going to start the
We're going to get started.
Shh. Okay, single payer update by Robertha, Sydney, and Michael. Okay, so this is the lineup. So we're going to talk about the need for a single payer system, then updates on the nationwide single payer movement, and then updates on state single payer initiatives, then the opposition. So I wanted to start by reminding everyone of the ACA's accomplishments. So when the ACA went into effect in 2014, the number of uninsured and underinsured rates dropped dramatically and continued to fall in all at-risk demographics. And then with the elections in 2017, we had a new administration who said that they wanted to continue improving the healthcare system, and Trump promised something fabulous with more coverage and better benefits, a lower cost, but as we can see, instead, all he did was try to repeal, so they tried to repeal the Affordable Care Act, and that didn't work, so I think they went about it in a more sneakier way and just undercut it in several ways. So in October 2017, they stopped reimbursing insurers for low-income deductibles and copays. Then in December 2017, they signed the Tax Cut and Jobs Act, which repeals the Obamacare tax on those who don't get health insurance. In January of last year, they proposed a plan to loosen regulations on short-term insurance. Then in February, they allowed states to impose work requirements on Medicaid recipients. And in May, they tried to do something about lowering drug prices, but as of yet, nothing has happened. So because of these actions, there was a reversal of the ACA's improvement, and the uninsured rate begins to decrease again in all at-risk demographics. So then I want to talk about the need. So the need is we need a single payer system because nearly half of American adults under 65 remain either uninsured or underinsured. And then I didn't really know what underinsured meant, so I found a nice explanation, which is annual out-of-pocket costs are greater than 10% of your income, or if you're 200% below the federal poverty level, then it's out-of-pocket costs are greater than 5% of your income, or your deductibles are greater than 5% of your income. Okay. So there's also an increase in excessive death because of the amount of people who are uninsured. And we also need a single payer system to resolve health disparities. So a lot of people know that there's a disproportionately high infant mortality rate in Black Americans than white Americans. And we've seen a slight decline over the past 8 years, but it's still high. There are other health disparities that need to be resolved as well, like the HIV diagnosis rate among teens has been steadily decreasing, but it's still significantly higher than white Americans. The teenage birth rate is still higher. Non-elderly Black adults also face disparities in terms of being reported as obese, having asthma. They're told by their doctor they have diabetes. And Black Americans are more likely to face challenges that affect health and access to care. Okay. It's also found something interesting, which is that your race can determine the type of insurance that you have. So more Black Americans tend to have more have public insurance plans and are not insured. And then it was found that women are paying more for insurance. Specifically, they're paying more for individual deductibles and family deductibles. Okay. So a single payer system makes economic sense. We spend nearly 20% of our GDP on healthcare, but our health outcomes are not any better and worse in some instances. So 60% of our healthcare spending is publicly financed, which is more than enough to pay for a single-payer system right now. And we save a lot with increased bargaining power, reduced administrative waste. There'd be no marketing anymore, and the risk pool would increase. Okay. So I found an interesting graphic that showed that we spend a lot more on administrative costs. And this graph also shows that the amount of physicians has been steadily increasing since 1970, but the amount of managers and administration has skyrocketed. Doesn't make any sense. We're also spending a lot on drugs, and as you can see, it's been increasing steadily. And I don't know if anyone saw Hassan Minhaj's piece on insurance companies, but I thought it was interesting that he mentioned that they don't increase the price. So I think his name is Martin Shkreli or something, that increased the price of a drug sevenfold or something. It was really high, but most drug companies are more sneaky about it and increase it a little bit every year. So I thought this graph showed that. And I need to hurry up. Okay, sorry. Okay. I also found that they're making a lot of profit. So I think in school they try to say that they need to charge that much because there's so much that goes into discovering the drug and research, but they're actually making a lot of profit, especially when compared to the Fortune 500 median companies. So
All right, so now I'm going to talk a little bit about the national healthcare reform landscape. So there's been a lot of exciting developments. It's been kind of a big topic of debate amongst the presidential candidates who have announced so far. It's really come to the forefront as it did in the last election as well. And there's a lot of healthcare reform bills in Congress now, and they fall into two major categories. So the first is public option, and the second is true single-payer plans. So I'm going to talk about what a public option is and why this is important for our movement. So a public option generally can fall into two different categories. So you can have expansion of existing government plans like Medicare and Medicaid, or you can have, and this is generally the focused plan, which is a new government-run healthcare plan that competes against private insurers in the marketplace for people under 65 who are not eligible for Medicare. And the goal of this is to fill in the gaps in places where insurance options are limited and offer more competitive prices to ensure that all people have access to affordable plans, even if private insurers are raising their rates or exiting the market. So just giving people another cheaper option, that is what advocates of a public option say will happen. The problem with a public option is that it still kind of maintains our current system with private insurance, which is inefficient, it's expensive, it's fragmented. Patients still have a limited choice of provider. These networks are really restrictive. It leaves this employer-based system intact and doesn't guarantee choice of doctor, and will continue to lead to rising costs in our system. And private insurance plans can continue to raise their prices. So it seems like unlikely to reduce costs. A big feature of this is that opponents criticize is the idea of high-risk pools. So if you're offering a public plan against these private insurance plans, it's more likely that sicker people will fall into this public plan versus healthier people will fall into these private insurance plans if they can afford it. And it kind of maintains this hierarchical system of insurance. So this was a good graphic I found from PNHP. Breaks it down simply. So a public option doesn't guarantee coverage to all people, whereas a single-payer system, everyone is enrolled in this plan, So it's guaranteed. You don't have to sign up on the marketplace. A lot of us saw like the issues with the Affordable Care rollout. Getting people to sign up is always an issue. So that wouldn't happen with single payer. Public option also maintains copays and deductibles. It doesn't cover as much. Single payer would cover comprehensive benefits, ensuring choice of doctor, and doing more to control costs. So this was a more detailed table comparing the two. So everyone is enrolled at birth for single payer. You're covering all medically necessary services. This can differ for states or federal plans, and this has been a lot of the debate over like what do we include. And it would eliminate copays and deductibles and give people free choice of doctor. Single payer would also decrease administrative waste in our system. It would lead to more cost control through negotiating power and bulk purchasing of pharmaceutical drugs, hospital budgeting, also doing more like fee-for-service payments, progressive financing, and it would be more similar to Medicare in that it's like lifetime enrollment and more comprehensive benefits. So public option, currently there's a ton of different bills that have been released in Congress. So you can see the list here, there's 7 or 8, and a lot of these have a bill in both the House and the Senate. And these kind of vary between lowering the age of Medicare, expanding Medicaid, giving people a public option in the marketplaces. And a lot of these bills are being reintroduced again in this session. And this was a side-by-side comparison that PNHP developed. So you can see that this is the Sanders and Ellison plans from last year. So the single-payer Medicare for all plans, and they cover all medically necessary services. Although this gets a little more complicated with things like long-term care, which under the bill last year was just covered under Medicaid, so kind of maintaining what we have now. There would be no cost sharing under single payer. These public option and Medicare buy-in and Medicaid buy-in plans all maintain the essential health benefits of the ACA, which is still restrictive, and they maintain cost sharing. So these are the bills from last year, and it's been really exciting to see the rising support in Congress. So last year there were 137 sponsors between the House and the Senate of these two different bills. I believe there were 16 co-sponsors of the Bernie Sanders bill. So definitely a lot of movement amongst our representatives compared to in the past. So this was the Sanders bill from last year. If this thing goes away, there were 16 co-sponsors, and it was announced with like a lot of press, so that was exciting. However, this bill was lacking a lot of things, and PNHP has tried to push Sanders and now Jayapal to add more comprehensive benefits, things like global budgeting of hospitals, establishment of a national long-term care program, which is really critical to giving people benefits, full coverage of all medications without a copay, and excluding for-profit healthcare providers, so forcing nonprofit healthcare providers, or forcing for-profit healthcare providers to become nonprofit. So this is the new exciting bill, HR 1384. It has a different number this year, released last week, February 27th, by Representative Pramila Jayapal, and it was introduced with 106 original co-sponsors. So that's really exciting. The Senate bill hasn't been reintroduced yet, but will soon. So this is a table of the new Jayapal bill. So it's going to cover all medically necessary care, and this includes long-term care. It includes reproductive care, including abortion. It also will include dental, vision, hearing, mental health, ambulatory services, prescription drugs. Coverage is portable. It covers all U.S. residents, including those who are undocumented. It eliminates cost sharing. It also would do global budgeting of hospitals, which was something that PNHP was pushing for, and establishing a national drug formulary to promote the use of generics, and allowing an override of patents when drug firms are raising their prices. And this was a key recommendation that was found in the PNHP pharmaceutical proposal that everybody should check out. Health equity, it provides funding for underserved areas. This has been in prior bills as well. A newer part in this bill is that it overrides the Hyde Amendment, which bans federal funding of abortion. And then what's great about this bill is that it has a quicker transition period to single payer. So it would happen over 2 years versus the Sanders bill, I believe, was 4 years. So this, I think, would be very beneficial, getting people into these plans earlier, preventing people from kind of falling to the wayside over a 4-year period. So that's the gist of this bill. So it's been described as the most ambitious Medicare for All plan to date. It has pretty much everything that PNHP was looking for, including long-term care, abortion coverage, global budgeting. This overriding of drug patents, overriding the Hyde Amendment, and this quicker transition period. So PNHP has endorsed this bill, as have many other groups. The one concern that was not included is this idea of for-profit healthcare providers, so hospitals, nursing homes, dialysis centers. They can still remain for-profit instead of converting to nonprofit. So this doesn't quite take the profit incentive out of our system. So SNaHP, kind of alongside PNHP, is seeking coverage of all medically necessary care, including long-term care, and I think it's important that we all push for no for-profit providers or insurance alternatives. So guaranteed enrollment and guaranteed choice is a key part of any single-payer system. And there's been a lot of press coverage on single-payer in this past year, which I think has been one of the key advances. So this is a diagram of Google search terms for Medicare for All. There's been like a lot more spikes in the past couple of years. And it's really been kind of getting a lot of media coverage. Even the New York Times has covered Medicare for All, and the New York State bill for like the first time ever in the last few months. Meanwhile, Donald Trump is writing an op-ed in the USA Today saying that Medicare for All will demolish promises to seniors. Yeah, so now we let Sydney talk about the state bills.
So thank you to Michael and Robertha for that on the national level. So now we're going to switch to state single-payer bills. And I think this is an important discussion because there's a lot more flexibility and feasibility at the state level. So we have more opportunities to kind of play with different structures and think about our messaging and what's important to us. So right now we have single-payer state-based legislation in 18 states. 15 of those states are kind of struggling with it, so we're going to focus on 3 today, both in this discussion and the panel at 1:30. So it's becoming a much more popular topic now, especially after the 2018 election. So we're seeing a lot more energy, and it's really an exciting time for us. So California is politically complex when it comes to single payer. They have a really complicated tax structure. They have a large immigrant population. So there's a lot of issues with those topics, and so it's been hard to find a lot of political support, even though there's a lot of popular support, and the nurses unions are really pushing this, but they haven't seen the level of support that they need from the legislators. So last week was the deadline to introduce new legislation, and no Democrats stepped up to introduce the bill, so it's not going to happen this year. But there's a lot of support for it. We just need the political support as well. In Washington, they're taking a more cautious approach. So there's a demand for an economic study. They're trying to do that by summer of this year. And then they also created a working group to look into what single payer would mean for the state and to report those findings next winter. So that's not going to happen this year either. One thing that Washington does have going for it is Representative Jayapal, who Michael talked about earlier. She's awesome. And she created this bill, HR 6097. So that's different than the federal single-payer bill. It's a bill on the federal level that would improve the feasibility of state-based plans. So it would increase states' access to federal funds for their own state-based plans. So that's been a major issue with both Washington and California, is getting those waivers to be able to access the federal money. On the other hand, New York is saying, forget the waivers, we'll figure that out later, we just want to go for it. So we have the New York Health Act here, which has passed the state assembly 4 years in a row by a huge margin. And in previous years, it wasn't doing as well in the state Senate, but now for the first time in a very long time, we have a Democratic majority in the state Senate, so we're trying to get more senators on board. And there's a lot of popular support for it, a lot of political support, so we're really optimistic. And in terms of the content of the state-based bills, the New York bill is most similar to what Representative Jayapal introduced this year. So it includes job training assistance for people who would experience job loss related to insurance companies. It also includes long-term care, which I think is an important step towards health equity. Right now, the lack of affordability with long-term care disproportionately affects people with disabilities, and because people can't afford they can't afford to pay people to take care of them for home-based care, so a lot of that falls onto family members, disproportionately women. So this would increase funding for that care, which I think is a great step towards health equity and economic equality, gender equality. This bill also includes abortion, like the Jayapal bill. And let's see. And so the New York State SNaHP chapters have been really involved in trying to push for the New York Health Act. We have a business outreach campaign, we have 10,000 doctors for New York Health, and we do a lot of door-to-door canvassing, asking people to share their stories, just talking to people one-on-one about their experiences with health insurance and what they would change about their experiences. We have visitors to legislators, and students writing op-eds. So these are two different op-eds written by student chapters in New York City. So, and then there's 15 other states that we are not going to go into too much detail today. But you can learn more at 1:30. We're having a panel where we'll dive into the details on this. Okay, so that's the in-depth look at the state-based single payer. And then both nationally and on the state level, the more momentum we see, the more pushback we get. So there are people who stand to profit from our patients' illnesses, the private insurance companies, for-profit private hospitals, especially the bills that would eliminate for-profit hospitals. Obviously they are opposed to that because they don't want to become nonprofit. So there's pushback from them. Some providers don't take public insurance. A lot of dentists don't, for example. So they don't want to see a single payer plan either. Sorry. And then most disappointing to me is the American Medical Association's lack of support for a single payer. So they also oppose Medicare, and Medicare is incredibly popular now, so they were kind of on the wrong side of history then, and I think on the wrong side of history now. One of our board members, Jonathan, is planning a protest of the AMA annual meeting this coming year. So if that's something you are interested in helping with, you should let us know. And I was looking at the AMA website this morning, and one of their healthcare reform objectives is, quote, to stabilize and strengthen the individual insurance market, which is like the opposite of what we're trying to do. We're trying to get rid of it altogether. And tomorrow we are opposing this. We're protesting Pfizer. It's part of a broader campaign called Picket the Profiteers, so I hope some of you will be around to make it to that tomorrow at 11. So opportunities and challenges moving forward. We have done a lot of work. We've made a lot of progress recruiting our communities, recruiting our politicians, but a lot of it has been focused on medical students and physicians, and we need to move beyond that. We need a broader base of support. So we need to make sure that our messaging includes issues of economic equality, racial equality, gender equality, and we have to tap into grassroots organizing efforts and make sure that we're not just pushing our message, but really learning from other people what they want to see in their healthcare system, and then using our power as SNaHP members to bring that to them. And then we also want to make sure, on the same vein, that we are including all the medical services that we need. So long-term care is important, reproductive health services, including abortion, mental health services. So there's a lot of issues with access to mental health and oral health care with Medicaid right now. And so we want to think bigger than that when it comes to a single payer plan. And yeah, that's all we have. We have a few minutes.
Who is it? Who is it? Did someone raise their hand? Okay.
So I am totally in support that public option is way inferior to single payer.
But for purposes of political viability at this point, if public option were to come up,
We support it regardless, even though it's not as good. We often say in medicine, the enemy of the good is the perfect. So I'm curious what your thoughts are, and maybe on that.
Yeah, I mean, PNHP as an organization is not supporting a public option. It's kind of thought of as incremental reform that really won't improve the main issues with our system, which is equity, which is eliminating the profit incentives in our system. So it seems like, at least for us to put resources into supporting a public option seems like almost a waste of time versus supporting a single payer system, which we truly believe is the answer to many of the issues that we face. Anything else?
Yeah, I think also in the long term, it kind of weakens our messaging. I think most people don't really care about the details of all the different healthcare policies. So if people see the public option and think, okay, this is universal healthcare and it sucks, then we're not going to be able to get true single payer if we already set ourselves up with a weak failing system.
I would also just add that some of these plans have come together almost to distract people from our message. So there's been like Medicare extra plans, these things that sound like Medicare for all. So we need to watch out for those. We need to educate people that they're not single payer and just make sure that people understand the differences.
So I have a question about the for-profit provider piece. So the argument that I've heard, like, for the solution in the Jayapal bill is that it's not a question of, like, whether we should get rid of for-profit providers, it's a question of how. And their argument is that, like, the global budgeting system essentially stars for-profit providers of their profit. So getting rid of them that way, rather than having to, like, buy them out. Is there a PNHP argument in the opposite direction? Do you know? Also, while you're thinking, the CBO scored the public option and found that it did not increase insurance rates like at all. So not only like not as good, but not good at all.
Yeah, to that second point, yeah, I think PNHP has said that it won't really improve coverage. I'm not sure whether I agree with that. I mean, I think that it would somewhat improve coverage because you're hypothetically introducing a cheaper plan that more people will sign up for, and if people who are pushing this bill also push people to enroll more in this plan, I think it would reduce uninsurance a little bit. However, I don't think it would make a significant dent, but I think it's been found, some analyses have contradicted that. So the first point, I don't know if any of us are experts on that, but yeah.
So there are a few ways to sort of force the transition to nonprofit. As you mentioned, global budgeting is a huge one. There's also, I think it's in the Jayapal bill, not 100% sure, but prohibiting bonuses and pay for performance. So those are ways to kind of like subtly prevent people from making a profit. I'm not sure if PNHP has a formal stance on any of them.
Cool, thank you. Also, while I had the mic, Augie suggested that I say I'm Frances and I'm on the SNaHP media team. And if anyone here loves Twitter, please talk to me and get on the media team because it's really fun.
We're going to take a few more questions. We have like 5 minutes, and our keynote speaker is not here yet.
Yeah, I got a lot of voice. My question is, so looking at, you might hear this later in your panel, but you're talking about the healthcare rights and access survey that you're doing here in Europe. Has SNaHP or PNHP discussed at all doing a nationwide version of that, or taking any initiatives to do, like a nationwide data collection initiative at all? Anyone's heard anything on the board meetings or anything?
I don't think that's been a thing yet. I know that us from New York, we've tried to like share our resources and allow other people to do it, but I think it would be great to do that nationwide. It's also for medical students in particular. This kind of feels like a motivational interviewing style thing, like really like getting to know like how people feel about their healthcare. So I think it's a great thing for SNaHP to participate in.
I was just going to say that I think that's a really good idea and something that should be brought up to Adam when he comes, especially because in New York State we've expanded Medicaid, so a lot of people, like I found when we went door to door, people's stories weren't that bad, but when I lived in Missouri, the stories were horrible. Like I remember a family talking about a child in the family that they had to bury because they couldn't afford the expenses for their illnesses, and like crazy, horrible stories in these states that didn't expand Medicaid. So I feel like that's a great idea and something we should.
Hi. So I want to ask about the protesting at the AMA annual meeting in Chicago. I was wondering if SNaHP or PNHP has done anything to try to partner with the AMA to kind of change the conversation there. I know AMA has traditionally been a pretty conservative organization, but I attended the interim meeting this past winter and like trying to be more involved with the medical student session there. And there's a lot of movement that's happening right now. Like during interim, they were trying to pass in the medical student session like a resolution to support single payers, support universal basic income. At least on the student side, there's a lot of movement trying to move in that direction. And I think if you have the protester, there will be a lot of students that actually come out and support you guys. So I was wondering if there was like any outreach movement with the student section there, or maybe some like physicians who share your interests that are also part of the AMA.
Yeah, there's been a ton of support from the medical student section. We've worked with them in the past. The physician members are less supportive. Yeah. But Jonathan, do you want to speak more about that?
Yeah, thanks for the question. It's pretty good. Sort of like Sydney said, there have been SNaHP students who were also members of the AMA medical student section. So we're working with them to try and give them support for their resolution for single payer, which they've tried to get passed several times now. But like Sydney said, also the physicians are less forthcoming, but there are some, like in the local medical societies, who support us and want to see single payer passed. I think nationally, as long as the AMA is still going to rally opposition against single payer like they're doing right now with the Partnership for America's Healthcare Future, I think we have no choice but to go after them, frankly. So that's putting it mildly.
Hi, I have a question with regards to, I guess, the future or implementation of this plan. So are there any plans or any talks about restructuring the way, I guess, physicians are reimbursed? Because as it stands, you're reimbursed based on procedures. So how, like, are there any plans to restructure this to account for time spent with the patient? Because with this plan, what would stop, I guess, medical students from further going into high-paying specialties such as or with this plan?
I think this is where the flexibility in the state level comes in. I know in New York, we're trying to move away from fee-for-service, but the national Jayapal bill still uses fee-for-service. But that's something we should keep in mind. Thank you for bringing that up. Sorry we're running over time, but I don't know if our keynote speaker is here yet.
Keep going.
So I'll just preface by saying I haven't read HR 1384 or dissected it completely, so I don't know the elements that are included in it. But you know, the idea of increasing coverage is great, and it does a lot to sort of address those gaps in health equity. But if you have shortages of doctors or shortages of physicians in areas where patients need care, then it's sort of a moot topic. So does this plan or other single-payer plans also increase the funding available for graduate medical education, or funds to provide salaries for residents, or how is that restructured in these plans? Maybe you can give me some insight into that.
Yeah, I mean, I think that's a big issue. I think currently a lot of the medical education actually comes from like Medicaid funding, I believe, Medicaid and Medicare. I think that's not really something that's addressed with single payer. There would be more funding for like rural and underserved areas and like National Health Service grants. I believe that's in the bill. However, I agree that that's an area that we should be focusing on more. I think that the limit really is like the residency spots, because medical schools are growing. There's new medical schools. Like I know Kaiser just opened a new one. I think that that's been improving, but the residency slots has kind of stayed the same. So I see that as like the main issue.
And to that point, so there's a lot of money set aside for a retraining of people in the private insurance industry. There are a lot of people who have left clinical care to do administrative roles, whether that's nursing, whatever role that you formerly played as a clinician, who now get to deal with paperwork. And so there is money set aside to transition those people that would be out of a job back into new training. The other piece about GME, which is interesting, is that I'm going to get the number a little bit off, but about 100,000 is given per resident to hospitals. For those of us who are medical students in the room, we are money makers once we get to residency, and it goes up to about $250,000 each resident makes a hospital system. So there's actually some estimates just to say that GME funding right now is over reimbursed, and hospitals are really profiting from that. So it would be equitable distribution of that GME funding and putting a little bit more pressure on hospitals to say, you know what, maybe you can't build that wing in the hospital this year and hire a few more residents. And
from the PNHP side, this is so Hey everybody, I'm Keena. You probably got an email from me. I'm one of the national organizers. Hey, thank you guys. So, what I really want to stress is to you guys is really stretch your thinking in this summit. And I know it's going to be the nuts and bolts of what's going on just with the different campaigns, with the different pieces of legislation. But we gave a talk at Northwestern. Paul is here. Paul, raise your hand. Midwestern. Sorry, Paul, raise your hand. He's from the SNaHP chapter in Midwestern, and the students there really pushed me and Caitlin on what are we doing to create, to also look at the student loan debt crisis. Because there are a lot of people who will not go into primary care for the very reason that you're talking about. So I need you guys to really push the envelope on that and come up with creative ways, but it is something that we need to do on the federal level as well to alleviate, because we will need more primary care providers. So I'm gonna transition. We have a video to show, but our keynote speaker is here. Give it up for Adam Gaffney. Adam's been working hard. Did you want to say anything?
We're just going to show this video. Adam Gaffney was on Fox Business yesterday.
Adam was on Fox.
We're going to just show part of it, but it's great.
So that study that you mentioned, it actually estimated that overall healthcare spending would be lower under single payer. Okay, actually $2 trillion less over 10 years. Yes, more of that money would be going to the federal government, but overall as a nation, even according to that libertarian think tank study, we would be spending less on overall healthcare expenditures, which is what people care about. They care about how much they're overall spending on healthcare. Also, let me just add, we also have major problems that we have to fix. We have 29 million people uninsured in this country. We have 44 million people who are underinsured, which means they have insurance, but with gaps in the coverage so big, it's as if they aren't insured at all. 35% of Americans go without needed care due to cost. I would argue that that is unaffordable.
This is Adam Lashinsky in San Francisco. I'm going to ask the doctor a political question. Everything you have said on this program so far makes 110% sense to me. It's like brain dead obvious to me that everything you're saying is right. What do you think we have to do to get the people who don't see it that way to agree with you?
Well, first of all, a majority of the country already does agree with us. Every poll shows greater than 50% support for Medicare for all. A Reuters poll late last year found 70% support.
They don't know what that
70% support, even 50% support, around 50% support for Republicans. So I think people love this idea. People don't like their private health insurers very much. They don't particularly like Cigna or United Health. They could care less if they no longer had those companies covering them. What they care about is who they can go to as a doctor, where they can go to in terms of hospitals. They care about their doctors and hospitals and drugs they need. They don't care about the private insurance company that happens to be their coverage.
Dr. Gaffney, hold on, Heather, go ahead. If the hospitals and the doctors if the hospitals go out of business, the doctors all just no longer work because they're not getting paid below market rates, it says would cut their pay by over 40%. I mean, then where are you going for care if that happens?
Many nations have done this. None of them have had their hospitals close or their doctors flee for other countries.
That's not quite true, Doctor. That's not quite true. It's not quite true in the United Kingdom, where there have been hospitals closed down. I would just ask specifically one thing about the United Kingdom, a country I know very well because my wife was there for a month after a stroke that she had in supposedly the best brain care hospital that they had, Queen Square Hospital. It was filthy, Doctor. I was there for 1 month every single day. The equipment was falling apart. The medications were inadequate to the diseases. The penicillin-resistant diseases that all of the patients around my wife ended up getting led to some deaths in that ward. How can you guarantee that our quality of health care won't go down the way it has gone down in Great Britain as a result of their socialized system?
Well, I think there's 3 points I'd make. I mean, first of all, I can't speak to your experience, but overall, the healthcare systems of these countries are quite high quality overall. They have higher life expectancies than we do. They have lower infant mortality.
The number of penicillin-resistant diseases that they have in the United Kingdom is much greater than it is here.
I see penicillin-resistant bacteria all the
Much
time
greater
in
there.
the intensive care unit. I've been at multiple hospitals in the United States. These are problems that exist everywhere. Again, I can't speak to your experiences, and I'm not trying to invalidate them, but overall, these nations achieve better results with less money. In fact, in the UK, people love their healthcare system. It's like a national religion.
I want to hear Hold on a second. Gary, go ahead.
Has a highly popular healthcare system. Yeah.
Dr. Gaffney, first of all, you were damned with faint praise by...
All right, give a round of applause to Adam Gaffney.
Good morning, everybody. So thank you so much for having me. I am so honored to be here as the speaker for this important, critical, key day. This is a movement, and you are on the forefront of it, and you are the future of American medicine, so give yourself a round of applause. All right, so I'm gonna take this talk in a couple of different directions. I want to talk a little bit about myself, my past, how I came to be doing what I'm doing, a little bit about where we are in the single-payer movement, and then I want to talk a little bit about the future and where we're going. So I just want to reflect back, just to begin, back to my experiences in medical school, which I graduated in 2008, a long time ago. I know, I'm dating myself here. And I want to just describe two talks that I went to in medical school that I think, to me, sort of gave me the sense that these were the sort of the two souls of the American medical profession. So I went to one talk that was arranged. It was an evening after classes. It was a vascular surgeon who was giving the talk, and it was a sort of discussion about the business side of healthcare and the sort of, private, how to run a practice and the sort of entrepreneurial elements to it. And he kind of went on and on about running the practice, and most of it was pretty unobjectionable. He talked about, getting difficulties in getting reimbursed and how you had to fight with insurance companies. Okay, fine. But then I remember that this talk took this really dark turn, and it has stuck with me ever since. And I was at NYU downtown. The surgeon said something along the following. He said, the only, one of the big downsides you have to be careful about is that, in my practice, I'm obliged to take patients with Medicaid, and you really don't want people like that clogging up your waiting room. And in fact, the words he used were far more crude than that, and I won't repeat them. And I remember sitting there thinking, this is horrifying, but I remember I also didn't say anything at the time. I sort of let those words be said, didn't raise my hand and interject because no one else was, and the room was quiet. There was actually some nervous laughing, okay, hopefully nervous, I expect. And after it was over, I remember, talking with one of the classmates. We both discussed how disturbing it was to have someone, speak in this gross classist way about people who needed health care in his office. And we agreed it was ridiculous, but I regretted not saying something, speaking up then, every year since. I went to another talk, though, that was the actual complete opposite. Ali Fine, who some of you may know, he is the, give it up for Ali Fine. He is the past president of PNHP. He is the chapter chair here in New York. Ali, and he's a great person and a brilliant guy. He talked to us about single payer, and I had been already sort of sold on universal health care as a concept. I was already in favor of single payer, but I was blown away by Ali's ability to wield facts, evidence, policy, and pull it all together with a clear political framework, a clear moral framework. I was inspired, and I kind of knew, actually, this is where I wanted to go. This is the kind of person I want to be. This is the kind of doctor I want to be. Someone who can wield together facts, science, and again, with a moral compass and a political framework and a clear one at that. So, again, I think both of those talks
affected me in different ways. The first one reminded me of the importance of speaking up. And, you know, in the very hierarchical sort of tradition of American medicine, and maybe all medicine, that's often difficult, right? You worry about consequences to your career. You worry about, you know, how you're going to come off. But I think that, again, ever since then, I've tried to speak up, and we all have to speak up. And as long as you're doing the right thing, it's worth taking risks in life. And I've seen that again and again and again. That was the lesson I took out of that first talk. And the lesson I took out of the second talk is I want to be more like Ali Fine. All right, so just to kind of go through a little more of my life. The next thing I kind of learned was in medical school, I wasn't very, you know, SNaHP didn't exist actually. There were some PNHP chapters. I wasn't very involved. I was a supporter of single payer. I started a newsletter in our medical school that we wrote about issues of policy and politics, and that was meaningful. But then, like all of you, I went on to the next stage and had clinical training, and what happens? You often get pulled away from your activism, right? And that's difficult. But there's a key lesson, which is that the wheel turns and then windows open again and you have an opportunity to get back involved. So as a resident, I sort of got back into the issues of policy, politics. I got very involved in the PNHP chapter here in New York. And, you know, that was a really important moment for me. We did lobbying days up in Albany. It was also the moment of Occupy Wall Street, a time when the whole political conversation started to change in the country to focus on issues of inequality. And we really used that as a springboard at that time to interject healthcare into that discussion, to talk about healthcare for the 99%, right? And again, there's another message there, which is you have to seize each political moment as it comes and use it, again, for good to achieve your goals and to put your message into the conversation. And I think we did that. So again, the wheel of medical training turns. Residency, I was here at Columbia for residency. I did a chief year, which gave me some time to focus more on these sorts of issues. But then I went to fellowship. And I went up to Boston and did pulmonary critical care. And, you know, it's just sort of an odd path, I think, for a lot of us who are interested in sort of social justice of medicine and policy. It's more typical to take a primary care road, and which makes sense. In many ways, those issues are more sort of closely tied with that practice. But I think the lesson, the thing I would say to you is ultimately you do have to practice the kind of medicine you want to practice, and you can do what you want to do outside of that. But obviously you have to follow your heart when it comes to what is it you like to do day in, day out in terms of your clinical practice, and that's what I did. So I went up to Boston and, you know, again, and I'm saying this because I know that as medical students, you're already in this cycle of sort of being pushed in and out of the clinical sphere when you're pressed for time and you're stressed and you're strained. So you have to have a plan in advance of how you're going to deal with it. And I think what I'm trying to get at is there's going to be times when you have to step away, but that doesn't mean you don't step back into it once things open up for you. And those moments will come again and again. So I, went to fellowship up in Boston, and a lot of these are intense clinical periods. So I was in the wards and in the ICU and doing pulmonary consults and all the rest. But then things sort of cycled down again, and we had research time, and this was a moment to get back involved. And I did. The first way I did that was finding a community, just like you have now, just like you've already formed now, just like SNaHP is, both on the national level and at your chapters. There was like-minded people in Boston, PNHP, some of the earliest founding members, Marge Cohen and Gordy Schiff, who some of you may know. Yep. They were actually at the first meeting when PNHP was formed in 1986, which I'm going to get to in a second. They hosted, they do host healthcare activist dinners once a month, bringing together people from different parts of the medical community. And that's so critical, right? To be with like-minded people. There's nothing, when you are really getting hit hard in the wards, when you are being pushed to the limit in terms of your clinical responsibility, there is nothing like being able to take a step back, be around people who have a vision for the future that you share, who are interested in the policy and political issues that you are, and that you can that you can form relationships with and begin projects and do work together. So again, the wheel turns. Your abilities to take time out of your schedule will vary over your clinical training, but when you have an opportunity to get involved, find people that you find meaningful and that you enjoy being with and that share your political and moral vision. So that's more or less where I am now, and since then I've been focusing on policy and politics and also working in the ICU and managing to sort of fit that together. All right, so I want to switch gears a bit for a moment and talk about why this matters, why SNaHP matters, why PNHP matters as much as it does. Now, I'm not just going to talk to you about why single payer matters. That's very important, and I'm sure you've heard of me and others and are going to be hearing about why single payer matters a whole lot. And I think you're probably sold, even though you're continuing to acquire more knowledge and learn more and more. But I want to talk a little bit about why what we're doing from within the medical profession is absolutely critical. Because we have a very powerful voice. One of the things that I found very useful in terms of my work in policy and in activism was learning the history of where we came from, which I started really doing in medical school. I read books like Paul Starr's American Transformation of American Medicine, other books that kind of gave us a look back. And one of the, when you read the history of healthcare reform efforts, you realize the key role, for better or for worse, that physicians have played throughout history in healthcare reform, right? So the big, real first effort to achieve national health insurance was really the 1940s. After World War II. The New Deal hadn't achieved universal health care, even though many people within FDR's administration would have liked it to have done so. They didn't pursue it. They did under Truman. And this started probably the big first national health care reform fight that has a lot of parallels with what's happening today. All right. So what happened was there were many people in support. Labor unions were in support. But at that time, the medical profession was very homogenous. Basically almost entirely male, politically more conservative than it is now, certainly extremely white, neither diverse. This is things everyone knows. I don't need to talk about this. But it also spoke with a single voice, and that was the American Medical Association. The American Medical Association, in a famous chapter in history, went on a sort of all-out war against national health insurance. It took out big fees from its members. It had a huge war chest. It gave tons of money to a very innovative public relations company located out in San Francisco, I believe. It filled the airwaves, or the radio waves, I suppose, and it, did basically a large-scale grassroots movement that really turned political opinion in the United States against national health insurance. There were other factors, but they beat it. All right? And that was the American medical profession then. Now, that being said, we've never been a homogenous voice. There's always been different voices within the American medical community. Just to give you a little sense of, even some of the predecessors of SNaHP, right? Medical students before you have, in fact, taken stands in brave ways. So even during the era that I'm talking about, the 1940s, there was a group called the Association of Interns and Medical Residents, AIMS, and medical students, I'm sorry. And they actually took a stand on issues like racial justice. They actually came out in favor of national health insurance. This is the 1930s and 1940s. Bernard Lown, who is a renowned cardiologist, who many of you may know, and basically developed the defibrillator and lidocaine, and I think he shared a Nobel Prize, if I recall correctly, for peace efforts. In any event, he was part of that. So that was one predecessor to, I think, SNaHP. Another predecessor was in the civil rights era, right? So again, the American Medical Association in the 1960s was very conservative. Did not take strong stands at all on issues like racial equity. They were adamantly opposed to Medicare, and after Medicare passed in 1965 and people began talking about, all right, well, let's try this national health insurance thing again, they came out against that. Well, in sort of opposition to that, there was an organization formed called the Student Health Organizations, and these were organizations mostly of medical students and other health professionals that took a very progressive attitude to issues of racial justice, to national health insurance, and they fought the good fight. Some of those students actually, even before that, went down to the Deep South during the Civil Rights campaign to sort of provide a medical presence for civil rights activists. Actually, again, not to go back to Ali Fine, but he was in the Student Health Organization in the late 1960s. So, again, there's always been other voices, and that was one of them. And look, the fact is that those voices changed the conversation, even if they didn't win the day. And that's why we're still here fighting, right? So how does PNHP factor into all this? And I'm going to come full circle again why I think the medical profession is so key. And it's not just because of the fact that the AMA defeated national health insurance in the 1940s. But let me just finish up this history quickly. So as I said, national health insurance defeated in the 1940s gets slimmed down into Medicare in the 1960s. Basically, the architects say, all right, they didn't call it single payer then, they called it national health insurance. So bear with me in terms of the terminology. They said, all right, we haven't achieved this in terms of the nation. Why don't we focus on seniors? Because seniors are sort of an easier group to target because private insurers aren't as interested in them because they're not really a good bargain, right? In terms of health insurance. Sick, obviously, don't have a lot of money. So they achieved that, but within, again, this is the 1960s, within years of Medicare being implemented, Medicaid and Medicare being implemented in 1966, people are back at it. Labor groups, progressive medical groups are saying, all right, now we take this and we expand it to everybody. Again, they call it national health insurance, they didn't call it single payer, but they were talking about the same thing. And in 1970, Ted Kennedy introduced something called the Health Security Act, which is basically single payer. Covered everybody, no copays, no deductibles, the same kind of thing we're talking about today. And there was a real sense that that could be won, that was a winnable battle. In fact, and maybe you're familiar with this, but Richard Nixon, in order to counter that plan, came out with his own plan that, by the standard of today's Republicans, was fairly liberal, and that it basically was pretty much like the Affordable Care Act. It mandated employers to provide insurance. It created, expanded opportunities for low-income people to be covered. For a variety of reasons, neither plan, there was a lot of hope there would be a compromise that would be achieved. Neither plan won. The country starts taking a right-wing turn. In the late 70s, Ronald Reagan is elected, and really a whole generation of national health insurance ends. People stop talking about it. It seems like it's no longer even something that's, a feasible idea, right? They're worried about just not having Medicaid be demolished at that point in the 80s, right? Just focusing on rearguard battles, focusing on poor people's health care not being totally taken away. And it was. In 1982, California slashed its Medicaid program and threw tons of people off of it. So these were dark eras. So what do you do when that happens? Well, stand up, fight back, right? And that is when PNHP formed. PNHP formed in a very dark time in American politics in the mid-1980s when Reaganism was the political dogma. Formed in 1986, and in 1989 they put out the physician's proposal, the single-payer plan that has somewhat changed over the years, but not that much. And they stuck with it. They got it out there, they got on TV, they talked about it, and they kept pushing away, and they didn't let it get weak, and they didn't dilute it, and they didn't walk away from it. And that was a very adverse political climate. But over time, the moral arguments won. It took a long time, right? Their proposal, our proposal, physicians' proposal, was basically rewritten into a bill in 2003. That was the Medicare for All Act of the House of Representatives, 2003, introduced by John Conyers. That bill was in Congress year after year after year after year, not too many co-sponsors, not too many co-sponsors over time. And then what happened in the last few years? We continue to plug away. The Affordable Care Act was achieved. It helped many people, 20 million people less uninsured, but left all of the main dysfunctions, all of the main inequalities and injustices in the healthcare system persevered, even though things had gotten better for some. Well, it's now the center of the political discussion. Within the last few years, the number of Democrats in Congress supporting that legislation went from, a few dozen to up to 2/3 of Democrats in the House. The Medicare for All is now basically at the center of the health care reform discussion in this country. This has been the role of PNHP, to push this onto the center stage, okay? But the fact is we still have a long way to go. The people who started the organization got this idea out there, put it out there, made it familiar, gave it a term, gave it a name, but now it's our job to actually see it achieved. So why do I think that we can do that? Well, I think, again, I said that the role of the medical profession is critical, and I believe that. And in some ways, you might push back and say, well, do we really have the power that we had in the 1940s, right? And the answer is, in many ways, no. Physicians are no longer the big, powerful healthcare lobby they once were. Health insurers are far more powerful than physicians, right? Pharmaceutical companies are far more powerful than physicians. Those are industries that in the 1940s, in the case of, the health insurance industry barely existed, the pharmaceutical industry existed, but was nowhere near the multi-billion-dollar powerhouse that it is today, right? So we are no longer the most powerful voice, but as a moral voice, we are still listened to. We as physicians are given unique responsibility in society in terms of, in the name of healing, what we can do to people to make them better, how we can intervene in their lives. We are given that unique responsibility. And with that responsibility comes a degree, I think, of respect, and we are given a microphone, and we are given a voice, and we are allowed to use that voice. And so really the only question we have to decide is how to use it for better, for good or for worse. And I think if we use it for better, we can, in fact, win this conversation. And we are going to be one of the critical voices. We're not the only voice. There's many other groups. There's many other grassroots groups. Physicians are one small part of this battle, but we are a key part. And our role is it's twofold. First of all, physicians, like nurses and other healthcare professionals, are not just one more stakeholder in the healthcare system. There is no healthcare system without healthcare workers and healthcare professionals, right? We're central to it. So we can't make single payer happen without having the healthcare professions on board, and we need the healthcare professions on board in order to be able to have the political force to get this through. And we need our voice of PNHP to continue to hold everyone's feet to the fire, to allow the vision, the program, the policy to be undiluted, to make sure the ideals stay true and we don't wind up falling back and into something that will allow all these dysfunctions and injustices to persist. So I want to, close up just by, again, imploring you as you're going about your coming days, coming years, a few things. First, speak up and take risks, as I said. I've already covered that. That was the lesson from the vascular surgeon. Two, the lesson from Ali Fine, which is we're not all going to be researchers or policy experts, but we need to all be experts to some degree on these issues. To speak powerfully, you need to know the facts and figures. And even if you're a clinician or even if you're a researcher who's studying, paramecium and various cell conduction systems or whatever, you still need to know the policy stuff, right? You need to be an expert in that, and you can be. If those, talking heads on Fox can bloviate about healthcare and, why can't plastic surgery be a model for the American healthcare system, then, damn right we can too. The next thing I want to say is look for the injustices that we talk about with the numbers with your patients. And I haven't always done that as much as I should. It's very easy, especially in some place like the ICU where you're just focusing on the sodium and the creatinine and the urine output and the central venous pressure and so on and so forth and the numbers and what's ahead of you and all your tasks, to sort of forget the patients that are in front of you and to not take notice of the ways in which the harms and the inequities of our healthcare system are manifested in their lives. I'll just tell one story that I think, of a patient who gave me permission to tell her story, that I think speaks to where we are today. And it's not the most dramatic story in many ways. I think it's fairly mundane's the wrong word, but commonplace. It was a woman in her 40s who basically had a history of hypertension and had been seen for some time by doctors, but hadn't been treated for a variety of reasons. And then one day she shows up after not being seen for about a decade in the emergency room with blood pressure, I forget the exact number, but it was somewhere around systolic of 240 over whatever, high 100s, hypertensive emergency. But it was a hypertensive emergency, right? Because she had multiple organs that had taken hits. She had a reduced systolic function. She had congestive heart failure, pulmonary edema, peripheral edema. She actually had cerebral edema. She had blurred vision. She had headaches. She had kidney injury, all of the common manifestations of long-standing hypertension. Right? So this is not, there's more sort of horrible stories and unique stories in this. This is sort of straightforward, untreated hypertension. It's probably one of the ways in which not having health coverage actually winds up killing a lot of people, because it's something that we can really do something about. And I asked her when we went in the room to see her, I said, I saw you used to be seen and you kind of disappeared for 10 years. What was that? I didn't put any words in her mouth. And she said because she lost health coverage at some point and got disconnected from the system. And that's the face. I mean, now this, obviously we use intravenous drips and we do what we do in the ICU to bring down our blood pressure, but those organ dysfunctions persevere, right? She doesn't walk away from this unharmed. That's preventable. And if you look, you'll see things like that, not every day maybe, not in this straightforward way, but you'll see things like that play out, and keep note of them, make note of them, take down those stories, write down those stories, and tell those stories if it's appropriate and in terms of protecting patient privacy. Because that's why we're doing what we're doing, right? We can talk about national health expenditures. We can talk about all of the problems of our current system. We can talk about financial incentives. We can talk about the flaws of pay for performance. We can talk about, the study which finds X, Y, and Z. But we're doing it for human beings ultimately. That's why we're all here. And we're at the precipice right now of a real change in the conversation on this issue. I talked about the history of healthcare reform efforts. There has never been a moment of where single payer, used to be called national health insurance, sometimes called Medicare for all, take your pick. There's never been a moment that it's been seemed so promising as the 1970s. So that's where we are right now. And our job is to make sure this is not another closed door, that this is not another lost opportunity, that this time we actually see the policy made that we know is necessary to improve the lives of our patients, that we know patients like the one I had, who had horrible untreated hypertension for so many years, the inequities of our system that hurt people like that. So I'm going to close out. Thank you again for having me come talk to you today and take up this time. I really am honored to be here talking to you. I think where SNaHP has come in recent years is absolutely incredible. This is the current medical student movement that is going to be the future of the American medical profession. So give yourself a round of applause. Thank you for having me. We are going to win this, I promise you. It's going to take a while.